Dear students, in this video, we are going to talk about the different pressures, the physiology of the pressure waveforms, that is the central venous pressure, the pulmonary artery occlusion pressure, and the arterial pressure. Now, this is a very important subject, both from practical point of view as well as from the exam point of view. And understanding this, the basic things will make the diagnostic process easier once you look into these waveforms. Now, let us start with an illustration. The case is a 40-year-old male, the day second post-operative following left pancreaticojejunostomy. Patient presents with tachypnea, with increased work of breathing, is mildly febrile. The pressure is on the lower side of the normal, has a bit of tachycardia, saturation is normal. Respiratory rate shows 36 per minute. Urine output is normal. The CVP is 7. And the post-operative wound dressing is hindering the placement of a USG probe to guide into the hemodynamic status on the basis of the ultrasound findings. Now, in these patients, can we be used central venous pressure be used to guide fluid resuscitation? Now, this is an important subject on which we have to understand the various changes in the central venous pressure that occurs and how they occur. So if you see in this column, the stroke volume is on the y-axis. The LV, left ventricular end diastolic pressure, is on the x-axis. So we know that when there is an increase in the volume, so there will be an increase in the stroke volume as long as the patient is on the smooth part of the curve. So a change in the central venous pressure, which we can represent as delta CVP, that is determined by the change in the volume of this blood within the thoracic veins divided by the compliance of these veins. And this follows an equation where the change of CVP is represented by the change in volume by the CV, or the total central volume. So now how to understand this and interpret this? So if you see this central venous volume versus central venous pressure curves, you can find that there is a point A on the compliance curve on the thoracic veins. If the blood of the volume within the veins is increased, then the operating point will shift up and to the right from A to B. So this represents increased venous return. And this occurs along the same compliance curve, that there is no change in the compliance of the thoracic veins. So now this will lead to an increase in the pressure, because you can see that on the pressure side, the point B is towards the right. So that indicates that there is a rise in the pressure, and that is determined by the change in volume and the venous compliance. Venous compliance is the slope of the curve along which this change is occurring. Now, CVP can also increase if the venous smooth muscle contraction is enhanced. Now, what can cause an enhancement of the venous smooth muscle contraction? It is the sympathetic nerve stimulation. Any kind of sympathetic surge can produce the same effect, but in that case, the venous compliance decreases. So you can see the dashed red line. So this represents the decreased compliance. So once the compliance, then also the pressure increases, but not at the same cost. So this occurs, the venous compliance decreases, and the new point is C. So the volume, change in volume, is much smaller, or almost same, or not much at all in comparison to what it has B. So central venous pressure can occur as a consequence of both these factors, either because of an increase in the venous volume, or as a result of a change in the compliance. So this is very important to know in any patient, that whenever you need to read the CVP, that whether this change in CVP is a result of the change in volume or the change in the compliance of the thoracic veins. Now, there are several factors which are responsible for increasing the CVP. Like if it is because of decreased cardiac output, the primary change is occurring in the volume. If it is increased blood volume, then also the primary change is occurring in the volume. If there is venous constriction, the primary change is in the compliance. when there is change from standing to the supine position of the body, we know that there is a shift in the volume. So the change is also in the volume. For arterial dilatation, also there is a change in the volume because the same amount of blood is accommodated in a much bigger vessel, so to say. Forced expiration, like during Valsalva maneuvers, so that causes an intense change in the compliance because of sympathetic activity. So there is a change in the compliance. If there is contraction of the muscle, both in the abdominal, in the leaves, that not only increases the venous return, but also produces a change in the compliance. So both changes would result in an increase in the central venous pressure. Now, if you see the central venous curve or the waveform, and also try to correlate with the various, the graph of an ECG, you can find the changes in the CVP reflect the kind of changes that we see in the ECG. Like if you click into the A is a positive wave on the CVP, and A marks the phase of atrial contraction. And P wave in the ECG, you can see it is the SA node initiates at atrial contraction, and the PR interval is roughly between 0.1 to 2.2 seconds and in 3 to 5 small squares. And as you can read that it is roughly this A is correlating, or it falls in the same line as the P's lower half. That is the descent of the P and the A is in the same line. So next wave we come across in a central venous pressure is the C, which is caused by raised atrial pressure as the tricuspid valve bulges towards the atrium on ventricular contraction. Now this again, if you draw a straight line from C, it goes to the peak of the QRS complex. QRS complex represents the ventricular depolarization time, and we know that contraction occurs during the systolic phase, and it has a duration of 0.04 to 0.12 seconds. So the changes in the C is merging with the changes in the ECG on the peak of the QRS complex. Then we come into the descent, that is the negative wave on the of the central venous pressure, which is the X wave. So the X descent is occurring due to the atrium being pulled down because of the ventricular contraction. So when ventricular atria is being pulled down, that definitely indicates that the ventricle has contracting or ventricular depolarization has started. So if you see the same thing, the QRS complex represents ventricular depolarization. So depolarization and contraction will together, and so you can see the S of the QRS is falling in line with the X descent. So this is where the atrium is being pulled down because of ventricular contraction. And therefore, ST segment marks the end of ventricular depolarization and start of ventricular repolarization till the appearance of T waves, which is caused by ventricular repolarization. So if you see again, the V, which is a positive wave, is caused by venous filling of the right atrium. Again, the right atrium pressure increases because when the ventricle is again, the repolarization has started. So there is filling of the atrium. And then again, it goes towards Y descent, where the tricuspid valve opens and the blood flows into the ventricle, causing this Y descent because, and this you can see roughly shows a flat line beyond the T wave. So once we know the changes, we can very clearly spell out that when it is the systole and when it is the diastole by looking into the central venous pressure waveforms and how these changes in the CVP would corroborate to the concurrent changes in the ECG. Now let us look here. Here you can see there is lost A wave because the atrial contraction is responsible, is caused by the A wave. Loss of atrial contraction results in the missing A wave. So this is typically which is seen in atrial fibrillation. If you look into this, again, you can see very clearly that there is a fusion of the A and C waves because the atrial contraction occurs at the same time as the ventricular contraction, and consequently, it results in the fusion of A and C waves, which we commonly call as Canon waves. Now, let us try to find an answer to this A-type question, very common in some entrance exams. that which of the following is true in relation to the Canon wave on CVP, the ones you have just seen. This represents a set of circumstances where atrium contracts against an open tricuspid valve. This happens with anterograde conduction of ventricular action potentials. It is never seen in complete heart block, where much of the time the atrium contracts against a closed or a partially closed tricuspid valve. Or D, as a consequence of this, in coordination between atria and ventricles, the ventricles are robbed of a substantial amount of preload. So I think you can well read out from the various choices that the answer would be D, because this is the ones which we showed where this fusion is occurring because the atrial contraction and ventricular contraction is occurring at the same times. And because of this incoordination, the ventricles are robbed of a substantial amount of preload because it is not dilating. In response to contraction of atrium, the ventricle is supposed to dilate to accommodate that blood, and because it is not dilating and instead contracting, that is the reason why it is robbed of substantial amount of preload. Next, if you see again another cause of in regurgitant CV waves, in tricuspid regurgitation, what happens? The backflow of blood out of the right ventricle that obliterates the normal X descent. Because if you remember, we had shown you that this X descent is because due to the atrium being pulled down during the ventricular contraction. Now, in this case, because of regurgitation, the same thing is not occurring. And as a result, the right ventricle obliterates this. The C wave becomes accentuated and fuses with the V wave, as both are the results of high ventricular contraction. And the V wave peak pressure is often the same as that of the right ventricular peak systolic pressure. Now, you can easily see this if you look properly into the screen in those patients of tricuspid regurgitation, that how they look like. And this diagram is also representative that how they look in contrast to the Canon waves. So this difference between Canon waves and the fused waves in regurgitant CV waves has to be understood and has to be recognized so as to differentiate between these two conditions. Next is accentuated A wave and accentuated Y wave. As you can see very clearly that in presence of tricuspid stenosis or reduced ventricular compliance, these waves can be seen in the central venous pressure. So let me ask a K-type question, another type of very common questions that are asked in entrance, that indicate which of the following statements are true or false with respect to the CVP waveforms in tricuspid stenosis. So as you know, in tricuspid stenosis, the changes are expected to be just opposite to those of tricuspid regurgitation. So you can work out the options on that basis also. Tricuspid stenosis produces a large A wave because of increased resistance to flow from the atrium to the ventricle. 2, the Y wave is attenuated because of a longer duration and of lower amplitude, because the right ventricular filling is slow and lazy without a pronounced change in pressure which would normally occur or tend to occur. 3, there can be absent A waves in the presence of a reasonably normal tricuspid valve with pulmonary stenosis or pulmonary hypertension. And this can also happen with increased myocardial compliance. So, as you can understand, the first two options are very true, and it is reasonable to comprehend them without any further discussion. If you seem to see, there can be absent A waves because in the presence of a reasonably normal tricuspid valve with pulmonary stenosis. So in these cases, because of pulmonary stenosis or pulmonary hypertension, there is a back pressure, and that is represented as a functional obstruction leading to the absence of A waves which are normally present. So this is not true. So A waves is represents the atrial contraction. So atrial contraction has nothing to do with the pulmonary stenosis or pulmonary hypertension, because here the changes will be seen in primarily in the V waves and in the CV. And this can also happen with increased myocardial compliance. This is also false, because increased myocardial compliance would lead to more ejection of the way. So there is no scope for a change in this. Now, another important is the bifid waveform, or which is seen in pericardial constriction, where the X and Y descent is steep and abrupt. So now when it is steep because of pericardial constriction, we can recognize it with this finding on the CVP. And this contrasts with cardiac tamponade, because here the Y descent is much prolonged. You can see clearly the difference. Here you can see the Y descent, and here you can see the Y descent. So which is much prolonged. So when it is much prolonged, so that represents the cardiac tamponade. So what are the informations that are derived from the arterial pressure waveform? So this all the way we have spoken about the central venous pressure. Now we are moving on to the arterial venous pressure waveform. We know that the arterial venous waveform, from the measurements, we can know the heart rate, can know the systolic pressure, the diastolic pressure. The diastolic pressure indicates coronary filling, because the coronary vessels fill during diastole only. The mean arterial pressure, which indicates the systemic perfusion. Pulse pressure, because if the pulse pressure is high, it represents certain conditions like aortic regurgitation. It may be low in cardiac tamponade or cardiogenic shock. Changes in amplitude associated with respiration, which is also known as pulse pressure variations, one of the indicators of fluid responsiveness or volume responsiveness in a patient. Slope of the anacrotic limb associated with aortic stenosis, because the morphology of this anacrotic limb changes in such patients. From the waveform shape, we can know the slope of the anacrotic limb, which represents the aortic valve and the LVOT flow. Slurred wave is seen in aortic stenosis. Collapsing wave is seen, or rapid systolic decline in left ventricular outflow tract obstruction. Bispherians valve in HOCM, that is hypertrophic obstructive cardiomyopathy. Low dicrotic notch in states with poor peripheral resistance, and also position and quality of the dicrotic notch as reflection of the damping coefficient. So whether the line is damped and needs to be fixed can be made out from the waveform. So the peak correlates with the systolic blood pressure as measured by the normal non-invasive cuff. So that is what we can find out. The trough, that is the lowest reading before the next pressure, which you can see, is the diastolic pressure. So the map is calculated from the area under the pressure curve. So if you can see the systolic and below is the diastolic, and between the two is the difference. You can find out the map, and the pulse pressure is the difference. So the map is calculated from the area under the curve. Now this has several components. If you look, you can find a systolic upstroke, which leads to the systolic peak pressure, followed by systolic decline. Then there is a temporary bulge, which is known as the dicrotic notch. Then there is a fall, which is known as the diastolic runoff, and followed by the end diastolic pressure. Now, what is the systolic upstroke represents? Now, systolic upstroke has if you can see, there is a slight more bulge to the peak. Then that is the reflected wave, and the one below it is the forwarded wave, and the difference between the two is the augmented pressure. So this systolic upstroke represents the ventricular ejection, and it corresponds to the peak aortic blood flow acceleration at the opening of the aortic valve. Now, slope of this segment has some vague relationship with the rate of change of left ventricular pressure with the competence of the aortic valve. But because of echo, we are not relying on them. We have other ways to measure them. If you look into the peak systolic pressure, it is the maximum pressure in the central arteries. We know that the central arteries includes the aorta and its main branches, and this is generated during the systolic ejection. The major contributions to this variable are the left ventricular contraction, central arterial compliance, and the reflected pressure wave that I had showed you, which is part of the augmented pressure. And the peak systolic pressure, and therefore also the pulse pressure, will be low in patients with highly compliant vessels. So if the vessels are compliant, they will be able to accommodate the change in volume because of rising pressure without much change in volume. Next is the distal systolic pulse amplification. You can see that these are the different tracings from the different arteries located at variable distance from the heart. So once you can see the aortic waveform, which is the central artery, then the femoral arterial waveform, which is distant from the heart, and then the dorsalis pedis arterial waveform, which is at the extremities, which is most distal from the heart. So if you see this, you can find that the change in systolic pressure, which occurs as a result of moving farther and farther from the aortic root, stacking more and more of the accumulated reflected pressure waves. So this reflected pressure wave, which you had seen initially, giving rise to this augmented pressure, becomes absent because of this overlapping effect of these reflected pressure waves on the top of the systolic peak as the distance increases. Next is the systolic decline. So systolic decline is the rapid decline in the arterial pressure as the ventricular contraction comes to an end, and the fall in pressure represents a period of time during which the efflux of blood from the central arterial compartment is faster than the influx of the blood from the emptying left ventricle. So you have to just imagine that the rate at which the heart is pumping or ejecting through the aorta, if it is not the influx which is occurring, if there is a mild difference, so that difference is represented by the systolic decline. The decline is even more rapid when the left ventricular outflow tract obstruction is present, because in that case the fall would be very much clearly the blood won't be able to reach the peripheral extremities, but it will give rise to this decline. Then comes the dicrotic notch and the incisura. Whenever the aortic valve closes again, there is a sudden increase in the pressure as the aortic valve blood volume suddenly discovers that it has nowhere else to go apart from the peripheral circulation. So you can imagine clearly. So the latency of the dicrotic notch behind the systolic peak varies with the position of the arterial line, moving farther and farther from the systolic peak and farther as you go down. That is, as you move from the aorta to the femoral artery to the dorsalis pedis artery, so it goes farther and farther down this dicrotic notch. Then the diastolic runoff and the influence of arterial reservoir pressure. The diastolic runoff is the drop in pressure which occurs after the aortic valve has closed. So there is no flow from the left ventricle, but pressure does not stop suddenly, but it decreases gradually along an exponential curve. The reason for this is called something which is the effect is known as arterial cushioning, or the reservoir effect of pumping blood into an elastic tube. So some of the blood which is already there adhered to the vessels, they are coming and filling up. So it is not that this sudden fall is not present. Instead, a slow and gradual form is present. So this is known as the diastolic waveform. You can very clearly see in this picture how smoothly this arterial, the gray lines are showing that it is smoothly coming down. And the pink line reflects the reflected backward traveling pressure wave, and the purple color represents the forward traveling pressure wave. So the shape of this reservoir pressure plainly has some relationship with the characteristics of the reservoir, or in simple words, whether the vessel is atherosclerotic, whether it is very compliant or not. So if you can see the waveform A, this represents in a radial waveform of a 25-year-old person. You can see how smooth is this dicrotic notch and the incisura, and followed by a gradual A of the decline of the diastolic runoff. B is a 47-year-old and C is the 80-year-old. So as with age, you can see that the diastolic runoff becomes a bit less prolonged, and also this incisura and the diacrotic notch becomes less distinct because the nice compliant arteries of the youth produce less reservoir pressure because they distend readily in response to the systolic flow. In old age, the reservoir is much less compliant and the pressure generated by pumping blood into it will be higher, and this will deform the shape of this diastolic runoff. Now, in diastolic pressure and pulse pressure. In diastolic pressure is the pressure exerted by the vascular tree upon the aortic valve. So hardened non-compliant vessels will cause this pressure to be raised. Soft vasoplegic vessels of a septic patient will offer very little resistance and the diastolic pressure will be lower. So we know that in septic patients, we get a vasodilatory kind of shock. A widened pulse pressure suggests aortic regurgitation, as in diastole, the arterial pressure drops to fill the left ventricle through the regurgitating aortic valve. And a narrow pulse pressure suggests cardiac tamponade or any other cause of low output state like cardiogenic shock, massive embolism, tension, pneumothorax, etc. So this end diastolic pressure and pulse pressure also gives clue to the important underlying conditions that the patient is suffering from. So if you look into this, you can see is the pulses alternate high and low volume pulses, and this is indicative of LV failure. You can see collapsing pulse, which is seen in patients with aortic regurgitation or hyperdynamic circulation, pulsus bispherians associated with aortic regurgitation and HOCAM, and anacrotic pulse, which is classically associated with aortic stenosis. So one common, not common, but one K-type question which can be asked in the exams is that indicate statements as true or false in respect of arterial pressure wave of a hypertensive person with poorly compliant arteries, the thing that you just saw 3 slides back, and you can easily work out from the options. A, the non-compliant vessels do not stretch in response to systolic pressure, and thus the pressure rises rapidly at the beginning of the systole, resulting in steep systolic upstroke. 2, in the elderly, the reflection wave arrives late during systole before the aortic valve closes, thus reducing afterload and thus to myocardial workload. 3, the systolic afterload contribution from the reflected wave disappears in vasodilatation and appears with vasoconstriction. And 4, and it has been demonstrated that systolic pressure in the aorta decreases by about 10 millimeter of mercury when the manual pressure occludes the femoral arteries because of the distance, as you know. So this is false. The first option is correct, as you can very clearly understand. Second option is also false because the reflection arrives very early, and therefore arterial valve closes after, and therefore it increases the afterload and increases the myocardial workload. So it is just opposite of what it is stated. And again, in option D, that our systolic pressure in aorta increases by about 10 milliliter mercury when manual pressure occludes the femoral artery for the same reasons of the reflected wave. Next, coming to the pulmonary artery occlusion pressure. So 5 general indications are there for insertion of a pulmonary artery catheter: evaluation of hypotension of unknown etiology, evaluation of volume status, differentiation of non-cardiogenic from cardiogenic pulmonary edema, determination of the effects of potent vasoactive and inotropic drugs, and evaluation of left and right ventricular function. Now, this was what was believed way back 30 years back, may not be true for today when we have non-invasive means of knowing this, but the certain basic understanding of the same remains unchanged. That's the blood pressure is the product of cardiac output multiplied by systemic vascular resistance. Systemic vascular resistance is reduced in sepsis, in neurogenic shock, and in anaphylactic shock, and following the administration of certain drugs. The stroke volume depends upon the preload and the contractility, and the contractility is reduced in acute myocardial infarction, myocarditis, cardiomyopathy. The preload is reduced in dehydration, bleeding, cardiac tamponade, massive pulmonary embolism, tension, pneumothorax, all of which also reduces the stroke volume and ultimately the cardiac output. And abnormal heart rate like bradyarrhythmias and tachyarrhythmias can also lead to fall in the cardiac output. So if you see the pressures across the different chambers, so as the pulmonary artery moves from the right atrium to the right ventricle, then to pulmonary artery, and then finally it is wedged, the waveform also changes, and the pattern of this waveform indicates its passage through the different chambers of the heart. So pulmonary capillary wedge pressure provides an indirect estimate of the left atrial pressure. So it is true in patients where they have no arrhythmias, all the valves are normally functioning. There is no difference between the left and right side of the heart. Now, when a balloon is inflated and wedged in the pulmonary artery, the pressure tracing similar to the right atrial pressure tracing is obtained. As you can see in this figure 4, the peak of which you can find out. This tracing results because the left atrial pressure is measured indirectly in the wedge position. The waveform will be not as distinct in the wedge position as it is in the right atrium, because the right atrial pressure tracing is a direct measurement because with the tip in the right atrium, and the left atrial pressure is an indirect measurement through the pulmonary vascular system. So this was almost similar. So here you can see the P peak is 9 and here it is the trough is 6. So pulmonary capillary wedge pressure is 9 plus 6 divided by upon 2 is 7 and 7.5. So this is quite similar to the right atrial pressure, which is you can see on your left or on the figure 3. Now, how to suspect over-wedging? Because if it is over-wedged, that will not indicate the right pressure. So since fluid pressures decrease as the fluid moves downstream, the pulmonary artery wedge pressure will always be less than the mean pulmonary artery pressure. Over-wedging of the catheter tip is typically recognized by the loss of fluctuations in the pressure waveform. So it approaches more of a flat line nature, and there is a gradual increase in the measured pressure so that the measured pulmonary artery wedge pressure is greater than the pulmonary artery diastolic pressure. So this is one way of which we can suspect overwedging, and overwedging the balloon in the pulmonary catheter, which causes damping in the waveform. So this is one of the common source of error in the measurement of wedge pressure and can be difficult to diagnose, but it is important to diagnose. Otherwise, the measurement of cardiac output on the basis of this wedge pressure will be wrong. Now, what are the causes of respiratory variances in pulmonary artery occlusion pressure or wedge pressure? So in patients with spontaneous respiration, this wedge pressure decreases with inspiration because of negative pleural and alveolar pressures, which are generated by chest wall expansion and diaphragm contraction. With expiration, this pleural and alveolar pressure returns to zero, where the effect of these pressures on the pulmonary blood flow is minimal. In patients who require mechanical ventilation without PEEP, this wedge pressure increases with respiration because of the generation of positive pleural and alveolar pressures. However, with expiration, they again return to zero, and that is why wedge pressure is always measured at end expiration, where the effects of pleural and alveolar pressures are minimum. So this is something which is important and which may be asked during any of the Viva exams, and one should pay attention to this part. So respiratory variation on pulmonary artery wedge pressure is one reason why they should be measured from the pressure tracing instead of being calculated from the monitor. So that is an important piece of information. So the differential diagnosis from the various readings of the pulmonary capillary wedge pressure, you see that if the cardiac output is reduced, the wedge pressure is high, the right atrial pressure is normal or increased, and the SVR is high, that indicates cardiogenic pulmonary edema. If the cardiac output is normal, wedge pressure is normal, and everything is normal, but still there is edema, then it is indicative of non-cardiogenic pulmonary edema. If there is papillary muscle rupture, then there is again fall in cardiac output with increase in wedge pressure, and the changes are similar to the ones which in cardiogenic pulmonary edema. So we need to differentiate it through other means. In other cases also, like in septic shock early or septic shock late, this pulmonary capillary pressure will be reduced early and it will be increased in the later stage. And accordingly, we will also find the right atrial pressure will be reduced in the early stage and increased in the later stage, although the systemic vascular resistance is reduced in both stages because of vasodilation. So all the different conditions in which these changes occur can be worked upon using this. So right heart catheterization can be interpreted, and this is a very one-page diagram. Looks crowded, but if you watch it, you can clearly see what are the direct measurements, what are the indirect measurements, the RA pressures and waveforms, the abnormalities, RV pressures and waveforms, and the abnormalities in understanding the passage of a catheter into the pulmonary artery. Thank you very much. I hope this was useful.